So, can you hear me back there? Cool. Thank you very much, Warren and Steve, for the introduction, and thank you for the invitation once again. I'm going to give two talks today. The first is on how to investigate reflux disease, and the second is on how to manage esophageal disorders, because the speaker is not well, so he won't be here. So unfortunately, you're going to hear me dribble twice. So how to investigate reflux disease? Can you hear me now? Yes? Raise your hand. Can you? Yes? Okay. So, how familiar does this look? How often have you experienced a bit of reflux after a big meal or a nice drinking session? So, I mean, this is not just because you have a bit of reflux doesn't mean that there's pathology. So when is it abnormal and worthy of investigating with a view to being treated? Just to put things in perspective, a third of the Western world have symptoms of reflux. A third of those with reflux disease have problems with swallowing. And even those with dysmotility such as achalasia, many of them have also reflux-like symptoms, and on pH testing can have pathology. So those who have reflux symptoms that go to see their GP often are started on acid-reducing medications. And if symptoms persist, then they have an endoscopy. If they have esophagitis, they usually have their acid-reducing medication optimized. If it is normal, if on the other hand the endoscopy is normal, then and the symptoms persist, then they proceed with esophageal physiology studies. So not uncommonly, the most common patients that we see in physiology are those with a normal endoscopy. Indeed, acid-reducing medications heal esophagitis very well, but up to 40% of patients continue to have symptoms. And the cohort that we see are usually the ones that we call endoscopy negative reflux disease or functional heartburn. We don't know how patients will respond to the same insult of reflux. Some patients will have endoscopy negative reflux disease / functional heartburn. Others will develop erosive esophagitis, others Barrett's esophagus. But what we do know is that patients with endoscopy negative reflux disease respond have the highest symptom burden compared to erosive reflux disease and Barrett's esophagus. We also know that endoscopy negative reflux disease have the least response to acid-reducing therapy compared to erosive reflux disease and Barrett's esophagus. So the patients that we are most likely to see are the ones that respond least well to the drug that we have at our hands. So how do we investigate these patients? Firstly, we have to take a history. Not all reflux is reflux. We have to be very careful to exclude things like vomiting. Vomiting and reflux can overlap, and ultimately gastric contents are coming up from the stomach into the esophagus. So we need to be sure that these patients who have reflux disease indeed have reflux disease and not some other disorder before we proceed. So we should not be doing pH testing on patients who have vomiting, because ultimately it's going to come back as a false positive. What about this proton pump inhibitor test? Well, patients often receive proton pump inhibitors. If they respond, does that mean these patients had reflux disease? If they don't respond, does that mean they have reflux disease? Well, this proton pump inhibitor test is in fact a very poor predictor for defining reflux disease, although everyone should have had one done in the first place before proceeding to esophageal physiology testing. That doesn't mean that they had reflux disease, it just means that they responded. But as a definition of disease, we should not be using proton pump inhibitor as a test to define pathology. Barium swallows should not be used as a measure of reflux. When you get a barium swallow study and it says, oh, we did the siphon test and the reflux went up to the cricopharynx, that's not reflux disease. We have up to 73 reflux events occur within 24 hours. A 10-minute barium showing a bit of reflux does not imply that there is reflux disease. It might suggest there is an abnormal anatomy, such as a hernia, etc., but that doesn't equal reflux disease. So we should not be using barium to define the pathology. What about questionnaires? There's loads of questionnaires out there to define reflux. But in fact, studies have shown that questionnaires are no better than a gastroenterologist taking a good history in defining reflux disease. Endoscopy. Well, off acid-reducing medication, only 35% of patients will have esophagitis or Barrett's esophagus or some kind of pathology like peptic stricture. The rest of them are normal. And this is even less so in on PPI studies. So when you're doing your endoscopy, if the patients are on PPI and you're looking for reflux development, 85% of patients will have normal endoscopy. But endoscopy is important because we have to also exclude other pathology. We should not be doing pH monitoring on patients who have not had an endoscopy to exclude mucosal or structural pathology. Now, remember that we should all be speaking the same language, so the LA grade is important, and LA grade A, B, C, or D is how we should define esophagitis. And it's also important to remember that LA grade A does not equal reflux disease. Even LA grade B is unclear if this is true reflux disease. The only true definitions endoscopically of reflux disease are grade C and D. Grade A is equal, there's a very big overlap with normal. Grade B is dubious. Okay, it's all very subjective. Just like gastritis, if you do an endoscopy and you find a bit of redness in the stomach, one person's gastritis is another person's normal. So, patients have had endoscopy, have had a history, have had a barium, have had biopsies, it's all normal, but they're still complaining of reflux. This is when they come to us for esophageal physiology testing. Ultimately, why are we doing this? Patients who have anti-reflux surgery, what are the best predictors for a good outcome? The best predictors are patients who have typical reflux symptoms such as heartburn or regurgitation, patients who have at least a partial response to acid-reducing therapy, and a pathological esophageal acid exposure measurement. These are the three pillars that predict the best outcomes. And so it is these three that ideally should be fulfilled before anti-reflux surgery is considered. Now, ambulatory pH monitoring is why we're here, primarily. And so there are three different techniques. We all know of these. There's conventional pH monitoring, impedance pH monitoring, and wireless pH monitoring. So we'll talk about all three. Ultimately, they all do the same thing. They define the frequency of esophageal acid exposure during the day and the night, and they also try and associate symptom events with reflux events. And there's lots of normal values out there. The most common is here. Total reflux, which is in other words, acid exposure time. This is the most robust and reproducible diagnostic marker of reflux disease, not Demeester score. Demeester score helps. It's a nice thing that surgeons like to describe, but ultimately the most robust measure is total reflux. However, 4.2%. Does that mean 4.3 is abnormal, 4.1 is normal? I mean, and why 4.2? It just doesn't make sense. So on that basis, there was a getting together of reflux experts around the world, and it was determined that we should put things in perspective. Endoscopy, grade C or D equals reflux disease. You don't need to proceed with pH monitoring. Grade A or B is not clear. pH testing, anything greater than total reflux of 6% is reflux disease. Anything less than 4% is not reflux disease. The gray area is in between. Total reflux of 4 to 6% and grade A or B esophagitis. This is where the other measurements start to become important. The number of reflux events, the baseline impedance, microscopic esophagitis, or better yet, just repeat the test. Because 1 in 3 pH studies are different when they're repeated. Or change it from one study, impedance pH monitoring, for example, to wireless pH monitoring. Symptom association. There's symptom index, symptom association probability. These are both important. These are the only two that we use nowadays. And they define different things. They both have their advantages and disadvantages. I won't go through the differences today, but they're both useful. And studies have shown that if you're doing both, if both are pathological or abnormal, it is more likely that the result is true. While if there is a discordance between the results, then one wonders whether or not the result of the symptom association is true. The other thing is we should not be measuring symptom association in patients who have had less than 3 symptoms. In fact, I would even go as far as less than 6 symptoms, because then statistically it's difficult to define. So, we see in physiology endoscopy negative reflux disease potentially patients. So in other words, patients with reflux disease with a normal endoscopy. When you do a pH study, then patients can either have a pathological esophageal acid exposure, positive acid exposure time, or negative, or positive symptom association, or negative. On that basis, these guys are reflux disease, gastroesophageal reflux disease, and this group is functional heartburn. These guys can have anti-reflux surgery, potentially. These guys should not. But we're only looking at acid. What about impedance? So if you have 2 impedance sensors, first of all, impedance is the opposition to current flow. So when you've got impedance, the current drops from baseline to below baseline and then rises back up again. And that's what's important here. So if you've got 2 impedance sensors and you've got a tonic bolus passing across them, then the impedance baseline drops. As long as the bolus is touching the 2 sensors, the impedance baseline remains low. As soon as the bolus exits, the impedance baseline goes up. So the presence of these 2 impedance sensors can determine the presence or absence of a tonic bolus. If you put them in sequence, now you can determine the direction of flow. May it be a swallow or a reflux. And if you put them in association with a pH sensor, you can determine is this swallow or reflux acidic or non-acidic. And that's how it works. So it's theorized that impedance pH monitoring can improve diagnostic yield by up to 20% in experts' hands, because it can determine not just acid but non-acid reflux, the direction of flow, the number of reflux events, the proximity of the refluxates, and also associate all of this with symptoms. So with that in mind, now we can expand this algorithm from this to this. So now we have acid and non-acid positive reflux and symptom association, or negative. And so these guys are reflux disease. These guys are functional heartburn. Okay? And we know that as we go from erosive reflux disease to endoscopy negative reflux disease to functional heartburn, the likelihood of detecting acid reflux drops. The likelihood of detecting weakly acid reflux rises, and the likelihood of detecting sensitivity to mixed liquid and gas reflux increases. So that's why impedance is important. This study came out from the St. Louis group a couple of years ago, showing that when looking at all the parameters at hand, the most likely predictors of outcome following either anti-reflux surgery or acid-reducing medications is acid exposure time, which is obvious, as well as symptom association probability for all reflux events, acid and non-acid. So this is a measure of impedance-related symptom association probability. So these are the 2 best markers for detecting outcome following either anti-reflux surgery or proton pump inhibitor use. However, the same group who did the Lyon classification, they also did an update to the Porto consensus 2017, looked through the literature, and there is very little evidence that using impedance alone, in the absence of acid reflux measurements, impedance alone is a good predictor for outcome following anti-reflux surgery, and that we should only be using pH monitoring, acid, as a measure for determining if patients should have anti-reflux surgery. The impedance measures of reflux events should be added on top of the acid reflux, but not instead of. Does that make sense? So impedance is important, but should not be used as the determinant for anti-reflux surgery in the absence of proven acid reflux. So that aside, there's a new kid on the block. Let's take a step back. When you have any damage to the mucosa of the esophagus, one thing that can occur is dilated intracellular spaces. So the spaces in between the cells kind of widens, and it's a marker of damage. And this is what it looks like. So endoscopy negative reflux disease versus erosive esophagitis. This is dilated intracellular spaces. When you treat the patients, these spaces tend to reduce, and that implies a healed mucosa. So we can measure mucosal integrity by measuring the consequence of the damage versus healing. And this is from Phil, who is not here today, from his paper in 2013, showing that with acidic insult of the mucosa, the mucosal integrity deteriorates compared to healthy. So we can measure mucosal integrity using the impedance catheter. If you have impedance sensors in the bottom of the esophagus, you can measure the mucosal integrity of the mucosal wall. And you know that when you do impedance, there are some patients whose impedance baseline is just flat. You wonder whether or not this is you've done something wrong. But in fact, you haven't. This suggests that there is a poor mucosal integrity. There is damage to the mucosa. This is very likely to occur in patients with marked eosinophilic esophagitis, achalasia, patients with leaky mucosa of whatever cause, Barrett's. So one thing that you can do to measure the degree of poor mucosal integrity is the MBNI, the mean nocturnal baseline impedance. We do this at UCH now routinely. And you take, you measure the baseline impedance at 3 or 5 centimeters above the lower esophageal sphincter overnight at 3 different intervals, and you average it. Okay, so here's a full trace, an overnight trace. You use this sensor, and you average 10 minutes times 3. And anything lower than 2,100 ohms we consider to be abnormal. And it's proving to be quite useful and sensitive. There's another measurement called PSPW, post-reflux swallow-induced peristaltic wave. Now, this is interesting, but it's very laborious, so it's not come into routine clinical practice yet. What it does is it measures the ratio between of the number of times a reflux is followed by a clearance. So a reflux should routinely be followed by clearance. When you have lunch, we all are going to reflux. We then clear it with a swallow. But in reflux disease, this might not happen as often. And so there is an index, a ratio as to what is abnormal and what is normal. So Eduardo Severino in Italy has produced a lot of data on this, and it's proving to be quite sensitive and specific. However, it's very labor intensive. It's not automated yet. So this is, on the horizon. So what about catheter-based pH monitoring? This is the typical patient we have at UCH. Very happy, very comfortable, and no issues at all. From the functional gut clinic, I think that their experience is slightly different. Who here has had a catheter in their nose? Okay. Did you enjoy it? No. So patients don't behave normally. They are expected to go home, eat and drink normally, and behave normally. But in fact, how can you? You've got this thing sticking out of your nose. You're not going to go and have a walk down supermarket, go to the gym, and work out with this thing in your nose. When in fact, these are the things that you normally would do when reflux occurs. So local discomfort, poor tolerability, altered activities of daily living. So these things can impact. And also, not everyone gets symptoms every day. So what do we do next if patients are not tolerating the catheter? Bravo. Or wireless pH monitoring, if we've got SynMed here. A form of wireless pH monitoring. We sent an online survey in 2017 around the world to various labs. Some of you might have been involved in this. 91 labs responded. Question number 38 was, what happens if a patient referred for reflux testing does not tolerate the nasal catheter? 26% of patients would refer for wireless pH monitoring. The rest, that's the end of the line. So what is wireless pH monitoring? A capsule is placed in the bottom of the esophagus, and it sends information to a receiver. This is the old receiver, wirelessly. And it measures how much reflux events occurs over a period of time. Could be 1, 2, 3, 4, or even up to 4 days. And patients press the button to determine how every symptom that occurs, just like with catheter-based pH monitoring. It is more expensive, so according to NICE, we should only be doing this in patients who don't tolerate the catheter, because it involves an endoscopy. Patients prefer it to the catheter. It's better tolerated. They have a better experience, less restriction to their daily activities of daily living. By increasing the number of days you measure by 2, you double the number of symptoms that are recorded and increase your diagnostic yield by over 10 to 12%. This is the initial study in 2005. We have done, there have been several other studies that show the diagnostic yield can increase even further, especially if you increase the number of days studied to 4. In this study, where we looked at 3 different centers around the world, starting with 50 patients with with functional heartburn, basically, diagnosis of functional heartburn on day 1, negative esophageal acid exposure on day 1, having had Bravo. By day 4, the number of patients with functional heartburn had dropped by 1/3. So 1/3 of patients now have some form of esophageal pathology, either esophageal acid exposure or symptom association being positive. So, but when you have 2 days, 3 days, 4 days to measure, do you look at the worst day or do you look at the average? So it's a dilemma because it's 2 different results. In fact, we know from studies that when you look at worst day analysis, the sensitivity increases, sometimes even up to 100%, but specificity suffers. If you look at the average and you average the data as opposed to looking at the single worst day, then the specificity improves. We need to put these things in perspective, because all of us, if we have a wireless pH catheter done over 20 days, we're all going to have reflux disease. So one day, one of us is going to have esophageal acid exposure. So we have to put it, so when you do a worst day analysis, your specificity is very poor. And in this study, looking at 38 patients who have inconclusive results on catheter-based studies who proceeded to having Bravo, the diagnostic yield increased to 61% with average analysis and 76% with worst day analysis. So all these patients would have been considered normal and discharged had they not had wireless pH monitoring. We can also, since we have 4-day analysis, we can also study patients off or on PPIs. So when you have patients who are off PPIs for the first 2 days, if they have negative esophageal acid exposure, you can define them as either having an acid-sensitive esophagus, if they have a positive symptom association, or non-reflux disease. On the other hand, if they have a positive esophageal acid exposure, you give them on PPI study for the next 2 days, and then you can define them as either being PPI responsive or PPI refractory. So it's another way of looking at the data. How much more time do I have?
10 minutes.
Okay, good. But, we're not just, reflux disease is not just reflux. There's also the way the esophagus works. There's clearance. There's motility. Now, Andres is going to speak to you about motility later, so I'm not going to steal his thunder. But this is a typical normal high-resolution manometry study of a normal swallow. And I'll leave it at that because I want Andres to define all of this. But one good thing about this technology is that it can also define hiatus hernia. You can define the separation between intrinsic lower esophageal sphincter and the crural diaphragm. Sorry. And in so doing, we can also now measure a new parameter called esophagogastric junction contractile integral, which Andres is going to tell you about the distal contractile integral, which measures contractile vigor in the esophagus. This measures vigor in the gastroesophageal junction, and a low pressure, composite pressure in that area can predict poor integrity of the OGJ and suggest reflux disease. This is still early days. What about clearance? Well, it's not uncommon that in patients with reflux disease, when you give 5 mL of water, there is poor motility. Peristalsis is not very good. But sometimes, then, when you give a solid swallow to challenge them, in endoscopy negative reflux disease, the esophagus sort of wakes up and there's good clearance. While in erosive reflux disease and Barrett's esophagus, not uncommonly, it remains poor. And this is a healthy subject's eating. Okay? And so next time you swallow, you eat, just think about how you're eating. You swallow, you chew, you swallow, you swallow, you swallow again, and then the food kind of progresses. Then you chew, you swallow, you swallow, you swallow again. So it's not uncommon to have several swallows before the esophagus is cleared. But in reflux disease, on the other hand, this is more likely to occur. Severe reflux disease. You swallow, you swallow, you swallow, nothing's happening. And swallow, swallow, then if there is peristalsis, it's weak and hypotensive. And then it's at that stage the patient regurgitates. On the other hand, this technology is useful to exclude pathology. So 5 mL of water sometimes is very little to instigate a potential for the esophagus to act. And so in this case, this patient had 5 mL of water all throughout. There was no peristalsis. So this is a major motor disorder. But then when we gave him solids, suddenly the esophagus woke up. And now you can actually see a hiatus hernia. And this patient had a positive pH study, so they proceeded to have anti-reflux surgery. While here, the surgeon would be very apprehensive. We can also measure postprandial reflux and transient lower esophageal sphincter relaxations. And we can look at other things. So this is a patient with regurgitation. All intents and purposes, it's reflux. But in fact, when you take a history, it's not specifically reflux. You're getting spikes at from the stomach, and every once in a while these spikes go to the top. What is this? Rumination, indeed. So this is, and how many of you have had patients who have rumination who proceeded to having anti-reflux surgery? Because you're measuring one test, a pH study, which showed acid. Well, in fact, the acid is taking place due to a functional disorder. So in conclusion, ladies and gentlemen, not everyone with reflux needs to be investigated. So often just giving a PPI is sufficient. Unless you have alarm symptoms, then they need an endoscopy. Patients referred for physiology studies should have had mucosal and structural pathology excluded first. We should not be doing pH monitoring on patients who have not had endoscopy. We should have the facility to refuse them. Consider why we're doing the test and how it will help management. So, not uncommonly in units, patients have physiology studies done because it's a thing to do. That's not the right answer. Because we need to know what we're going to do with the result. If it's positive, what are we going to do? If it's negative, what are we going to do? If it's just for the sake of doing it, then you're potentially adding another disease, potentially adding another pathology when it's not necessary. If the patient's got LPR and then suddenly you start seeing there's a bit of resistance to the gastroesophageal junction, well, you just muddied the waters. What are we doing? Why does this patient have this? What are we going to do with this information now? So consider the best test. Is it acid, impedance pH, wireless pH monitoring? Different patients might require different things, and don't be afraid of moving on to the next test if one is negative and you're convinced with the result. So one test might not be enough. Don't limit yourself to a normal cutoff value. So total reflux of 4.3% is not abnormal, while 4.1% is not normal. We should look at the bigger picture. And symptom association is important, so we need to try and marry the whole thing together. If somebody's got a total reflux of 15 with no symptoms, that starts to ring alarm bells. And try and marry the reflux testing with the manometry results. Put it all together and look at the bigger picture. Thank you.